Today's topic on the conventional X-ray in the head and neck. Still they are reliable. They help the patient in management. The conventional radiography is no longer used as a primary diagnostic test for imaging of the paranasal sinus or the mystoid. But it is helpful in certain situations like when the symptoms of sinusitis are recurrent or refractory despite the adequate treatment, helps to plan any intervention for further investigation like the CT or the MRI, and it also helps where CT scan is not available, especially in the developing countries. What is the approach to conventional radiology for the head and neck or any imaging? We have to first assess whether it is a plain or a contrast study. What views are done, AP, lateral, oblique, or any specific view? Which region is covered, paranasal sinus, mystoid, or the neck? Then identify the normal structure. Once the normal structures are identified and the pathology can be recognized, which may be as a opacity, mass, or bone destruction, and then concluded as what is the radiological diagnosis which correlate or best correlate in relation with the clinical picture of the patient. The radiography of the paranasal sinus is widely popular imaging because it is easily available, simple and affordable to general public population. Commonly used in assessment of the sinus, especially in the developing countries. The clinician recommended plain radiography to consolidate the clinical diagnosis in suspicious cases and to plan further intervention or investigation such as a CT scan or a nasal endoscopy. Most clinicians prefer the conventional radiograph due to lower radiation dose compared to the CT and the faster scan time. The radiation dose in the conventional radiography is 0.0 millisievert, while in the standard MTCT it is around 0.7 to 0.9, which is quite high is compared to conventional radiography. But with development of the low dose CT scan, this dose is markedly reduced to 0.047 to 0.51. So it is much better than the conventional radiography. The X-rays are reserved for the patient with persistent symptoms despite the appropriate treatment. Always interpret the X-ray in conjunction with the clinical findings. The conventional paranasal sinus examination should consist of at least minimum 3 views: water view, cardiac view, lateral view. But few studies then conclude that the single water view provides as much information as the standard paranasal sinus X-ray. So to avoid the exposure to the patient should limit it to the single view. This is the water views which show the maxillary and the frontal sinus demonstrate well on the water view as compared to other sinus, and then we have to assess the opacification or any bony deformity. This is the caudal view of the skull that shows the frontal sinus and the ethmoid L sinus very well as compared to other, because the petrous bone obscures the maxillary sinus in this view. Then the lateral view of the paranasal sinus will show the posterior and anterior wall of the maxillary and the frontal sinus as well as the sphenoid sinus well on this view. Then what is the approach to sinus pathology? Whether there is a total sinus opacity which can be seen in the sinusitis, polyp, malignancy or mucosis, or the partial sinus opacity with the airflow level as seen in the acute sinusitis. Or there is any rounded opacity in the sinus which could be the polyp, cyst or enteroconal polyp, but in the enteroconal polyp the opacity extending to the nasopharynx. Either there is a dense opacity which could be the osteoma, or there is a destruction of the sinus wall which favors the malignancy mode. The conventional X-ray has a limited role in the management of the sinusitis because it is a clinical diagnosis. but imaging is generally indicated in the recurrent or complicated sinusitis. On the X-ray, either we see the complete opacification of a sinus or an ear fluid level, which these findings are more specific, but seen only in 60% of the cases. While the mucosal thickening, which is seen in more than 90% of the cases, but this is a non-specific finding, so it should be interpreted with the clinical correlation. This is the X-ray of a 30-year-old female with a headache and known case of the sinusitis. In this X-ray, there is a complete opacification of the left maxillary sinus without any obvious destruction. So, this is the case of the left maxillary sinusitis. This is an X-ray of a 10-year girl with a headache to show there is a partial opacification of the maxillary sinus with air fluid level, which is a sign of the acute maxillary sinusitis. This is the X-ray of a patient with repeated episodes of the sinusitis. The X-ray shows there is a well-defined opacity in the right maxillary antrum. This could be the maxillary mucus retention cyst, or it could be the sinonasal polyp. So, which further should be evaluated either with the CT or MRI. X-ray of a patient with occasional headache show a well-defined dense opacity in the right frontal sinus without any obvious bone destruction. This is the osteoma of the right frontal sinus. Then the nasal vein on fracture, the X-ray has a role with a sensitivity of around 80%. It is best detected on the lateral view, and the water view will assess in the nasal arch. When we report the nasal bone fracture, always comment on the displacement of the fracture, whether it is a displaced or not, because it has an important role in management of the patient. If there is a proper anatomical alignment, there is no further treatment is required, but in case of the displacement, if left untreated, it can lead to the unfavorable cosmetic result and also impaired respiratory function because of the deviation of the bone. This is the X-ray of the nasal bone. They show there is a normal alignment of the bone, but there are the few vertical deficiencies are seen in the nasal bone. These are the grooves for the anti-ethmoidal nerve. So don't interpret these as a fracture, because fracture are really horizontal. This is the X-ray of a 40-year-old male with a facial trauma. They show there is a fracture of the nasal bone bilaterally. But on an axial view, there is a displacement of the fracture side, left nasal bone is seen. So it is an important point that help in the management of the patient. Then the mastocytitis, it is also a clinical diagnosis. Usually, with the advance of the CT and MRI, plain radiograph are no more used as far as the mastoid imaging is concerned. But initially, when only the conventional radiography was available, multiple views were taken to avoid the interference of the adjacent bone. These include the lateral slump, extensor, Towns view, and the modification of these views with the position of the X-ray or angulation of the X-ray beam and the patient's head. But again, the few studies show the lateral mastoid or law view is the only projection still used in some areas where the facilities of CT and MRI are neither available everywhere nor affordable for everyone, especially in economically weaker countries. So the mastoid X-rays are still done. This is the mastoid X-ray series, the extensor view, law view, and the Towns view. They show there is a normal mastoid air cells with a honeycombing appearance, which is normal point. These are the normal X-ray with a clear mastoid air cells with a honeycombing appearance. But in this case, there is a slight haziness in the right mastoid air cells, and which is due to the acute mastoiditis. And on the left side, there is a bony defect is seen which is air-filled behind and superior to the external auditory meatus. There is no any surrounding sclerosis. This is most likely due to the defect of the mesophorectomy on the left side. This is another case that show there is a total haziness and sclerosis of the mesophoid cells bilaterally on the both views. This is favor of the sclerosing mesophoiditis. Then the lateral neck radiograph is a very useful imaging for evaluation of the suspected abnormalities in upper aerodigestive tract. It is relatively inexpensive, readily available and easy to perform examination. So in emergency setting when the patient comes with it is very good imaging modality to evaluate the upper aerodigestive tract, especially when the patient present with acute respiratory distress or a dysphagia. So to look for any foreign body or to evaluate the pharyngeal or retropharyngeal soft tissues, particularly in the kids. This is the normal X-ray neck soft tissue that show there is a air column of the pharynx with a trachea and here is the esophagus. This indentation is by the epiglottis and above is the ventricle and these are the pyriform fossa which are the dependent part of the pharynx. In the nasopharynx, we have to look for any radiopaque lesion and the nasopharyngeal air shadow. Whether it is displaced antero-inferiorly, it is occur in case of the adenoid, while in case of the endoconal polyp, there is a displacement of the nasopharyngeal airway posterior-superiorly, giving the crescent sign. The adenoid hypertrophy or enlargement is more common in the children, but it can also occur in the adults, but that is always pathological, some malignancy is there. Clinically, they present with the nasal congestion, chronic or recurrent otitis media due to the close proximity with the eustachian tube. Or there may be swallowing difficulty, hyponasal speech, rhinorrhea, or sleep disorder breathing. The lateral neck X-ray is the main imaging study to evaluate the adenoid and it helps in management of the patient. And management usually indicates there is a bed until it's resolved, or there may be adenoidectomy. It indicated when there is a significant compromise over the nasopharyngeal airway column, or there may be the recurrent and chronic sinusitis or mesophotic. This is the X-ray nasal, X-ray lateral of the neck. They show a soft tissue density in the posterior superior aspect of the nasopharynx, which is causing indentation and displacement of the airway column. So it is the adenoid which indent the soft palate. This is the X-ray of a young adult present ER with a respiratory distress. It shows there is a large adenoid along the posterior superior aspect, which is indenting the nasopharyngeal air column, and there is another soft tissue density, at a well-defined soft tissue density at the level of the soft palate, and this is the enlarged tonsil, which is also causing narrowing of the nasopharyngeal air column. This is the X-ray of a 7-year-old boy with rhinorrhea, snoring, and sleep disorder breathing. There is an enlarged adenoid which is causing significant narrowing of the nasopharyngeal air column. The enlarged adenoid is not of importance, but how much it is causing narrowing of the nasopharyngeal air column, it is more important. So this is the enlarged adenoid. This is the X-ray of a 5-year-old boy with the worsening of snoring for last 6 months and gasping of for breath while sleeping during the last 2 hours. It shows there is a soft tissue density at the nasopharynx. It displays and causing narrowing of the nasopharyngeal air column posterior superior. So this is the case. This can be an intraconal polyp, sphenoid and inverted papilloma, but as it displays the nasopharyngeal air column posterior-superiorly, so it is more in favor of the endogonal polio. Then on the lateral neck X-ray, the prevertebral or retropharyngeal soft tissues are very important to look. The maximum allowable thickness of the prevertebral soft tissue at the level of the nasopharynx include 10 mm. At the level of the retropharyngeal, means C2 to C4, it includes 5 to 7 mm. In the retrotracheal space, 5 to 7, it should be 14 mm in children and 22 mm in adults. The prevertebral soft tissue swelling in a symptomatic patient should be considered an indication for the imaging, further imaging. A 55-year diabetic female with a pain on swelling, doubtful about the fish bone injection about 4 days earlier. This is the X-ray lateral of the neck. They show there is a significant prevertebral soft tissue thickening from C2 to C7 vertebra with a few air loculi at the level of the C3, C4 and causing significant displacement of the hypopharyngeal air column. So this is the case of the prevertebral soft tissue. So this should be further evaluated with the cross-sectional imaging for proper extent of the abscesses. This is the X-ray of a 7-year-old child with 6 days history of the fever and right-sided neck and difficulty in opening the jaw. When we see with a careful evaluation, we see there is a interior displacement of the nasopharyngeal air column. This space should be up to 10 mm, but there is a significant displacement of the nasopharyngeal air column. So there is a retrotracheal nasopharyngeal. So there is a prevertebral soft tissue thickening. This is the diagrammatic. This is the expected soft tissue, expected pretracheal space, but it is extend up to this. So this is the case of the prevertebral or retropharyngeal abscess, and this should be further evaluated. Then the foreign body injection is a more common in children than in adults, but still occurs. In the children, the most common for ingested foreign body is the wines along with the toys, batteries, bone, whatever come they can eat and fit in the mouth they can eat. The X-ray of the neck, thorax and entire abdomen is recommended to localize the exact location of the foreign body. But the foreign body would extend or pass into the stomach and beyond. They pass spontaneously in around 80% of the cases. While in case of the foreign body in upper GI, they should be evaluated and they are mostly removed with the endoscopy. In adults, the fish and chicken bones are the more common foreign body. They usually locate at the oropharynx at the level of the tonsil, then followed by the valleculae, tongue base or in the piriform fossa. The foreign body above the oropharynx usually managed by the indirect endoscopy, but beyond the oropharynx they are localized by the radiological study epi and the lateral view of the neck, in which they can assess the foreign body in a hypopharynx or upper cervical esophagus in up to 70 to 80% of the cases. The prevertebral soft tissue swelling is a non-specific indirect sign, which in appropriate clinical context raises the possibility suspicious of a radiolucent foreign body or any related complication. This is an X-ray neck of a 25-year-old female with a sudden onset throat pain while eating chicken, but still managing to swallow food and the liquid. When we see the X-ray, in a first look, no any foreign body is such appreciated, but with a careful look, we see there is a linear opacity is here, which on zoom view is clearly seen in the piriform fossa. So this is a foreign body. This is X-ray of a 60-year-old female who complained of feeling a food stuck in the throat after eating meat. So there is a, on X-ray we see there is a mild soft tissue thickening in the prevertebral region at the level of the C6, C7, and there is a suspicious rounded soft tissue density beyond which there is a column of the air which is also dilated in the esophagus. So this raises the possibility of the impacted meat bolus, and this patient undergo endoscopy and show there is a meat bolus which was removed. This is an X-ray of a 35-year-old male with a suspicious of a fishbone incision. It clearly shows there is a linear foreign body at the level of C5, C6 level. So, X-ray of a 55-year-old brought to emergency department by her mother after the suspected foreign body applying incision. The X-ray showed there is a foreign body is there in the midline, but when we assess the diameter of the foreign body, it is exceeding the trachea, so it is most probably in the trachea, which can be found on the lateral view because it is posterior to the trachea. Posterior to air column of trachea. Posterior to the air column. So this is the foreign body in the esophagus. The point are really harmless, which usually do not damage the mucosa, but the bacteria the kids usually ingest, they are harmful. And they damage the mucosa, so we have to differentiate these on the X-rays. The foreign body point has a homogeneous density, while the bacteria usually show halo or a double rim sign on an X-ray, so it should be interpreted properly. 2 is a clinical diagnosis and usually self-limited condition with an overall good long-term prognosis. So imaging is not required mostly for the diagnosis. But AP and the lateral soft tissue radiograph and neck sometime are required to differentiate the flu from the other causes of the stridor and respiratory distress, such as foreign body epiculitis and the retropharyngeal abscess. The lateral neck radiograph detects the flu with up to 93% sensitivity and 92% specificity. The temple sign, staple sign on the AP view usually have does not have a high sensitivity because it is also seen in cases of the epiculitis, and in some cases of the flu, this sign even cannot be detected. This is an X-ray of a 2.5-year-old child with a stridor that shows there is a significant narrowing of the proximal trachea and the subglottic region, which give a staple sign, and then there is a significant distension of the hypopharynx on the lateral view. So this is the case of the flu. This is an X-ray of a child with a sore throat and drooling. There is a significant thickening of the epiglottis. Significant thickening of the epiglottis gives the thumb sign with a significant thickening of the aeroepiglottic folds. So this is the epiculitis. Then some cases on the barium study also, the upper GI. The esophageal web is a construction. Esophageal web is a construction caused by a thin mucosal membrane projecting into the lumen. They are most commonly seen in the cervical esophagus and usually they are arising from the anterior wall of the esophagus, not the posterior wall. And they can be circumferential. The pelvic Wilson syndrome is an important association. So on a barium or a contrast swallow, it appears as a shelf-like projection when the esophagus is fully distended with the contrast. This is a spot earth film of the barium swallow of a 20-year-old female with dysphagia. There is a radiolucent ring in the hypopharynx with a proximal dilatation of the proximal dilatation and hold up of the contrast. This is in favor of the esophageal web However, there is a opacification of the distal esophagus is noted, so it is causing the partial obstruction. When there is a partial obstruction, the jet effect is also noted on the fluoroscopy. This is a case of the 25-year-old male with a dysphagia. They show there is a radiolucent ring and lower and hypopharynx at the level of C5, C6 with a proximal dilatation and a hold-up of the contrast. This is another case of the esophageal valve which is causing partial obstruction. Because when it is causing dysphagia, the management is required, otherwise they usually are asymptomatic and found incidentally. This is the X-ray spot film of the contrast swallow of operation with the dysphagia. They show there is a smooth indentation along the posterior wall of the esophagus at the level of C5, C6. It is not along the anteriorly, so not even circumferential. So this is the cricopharyngeal valve, which is always along the posterior aspect of the esophagus. This is a spot film of a contrast swallow of an 80-year-old male with a dysphagia for 3 months. EGD was unremarkable. The contrast swallow show there is a focal contrast outpouching along the posterior aspect of the hypopharynx. And it is causing mild indentation on the esophagus, and but contrast has passed, so this is the Zacchus diverticulum. It is the pulsation pseudodiverticulum that arises from the posterior wall of the hypopharynx through the Cleon's descent between the cricopharyngeal muscle and the inferior pharyngeal constructor. These are the spot films from the barium swallow of a patient with a coughing and choking on foot. They show there is a contrast with outpouching along the anterolateral aspect of the esophagus, not the posterior as seen in the Zacchus diverticulum. So these are the Klein-Jensen diverticulum. These are also a pulsation pseudodiverticulum that arise from the lateral wall of the cervical esophagus below the cricopharyngeal muscle. So in conclusion, the conventional radiography is relatively inexpensive, readily available and easy to perform examination, but it is a limited role in management of the disease. Even though CT MRI have a good soft-tissue resolution, but they have their own drawback because of the increased cost of investigation and not widely availability in developing countries. Acute sinusitis and mastocytitis are clinical diagnosed, so no need of imaging, but in case of the complicated and refractory sinusitis, need diagnostic imaging including the conventional X-rays and the CT. The imaging, especially MRI or with or without MRV, can be done in mastocytitis that are not controlled with the antibiotics due to its complication, particularly the intracranial complications, which are very frequent. The lateral leg X-ray is helpful in evaluation of the suspected abnormalities in the upper aerodigestive tract, especially in the emergency setting, to assess the position of foreign body or to assess the retropharyngeal soft tissues, particularly in the kids. So this is all about